excited about this one, guys.
Me too.
It's gonna be good. We put a lot of work into this to make it fun for everybody because AHIP is never fun. And so I hope y'all enjoy everything we're going to share today.
Thank you.
Okay, here we go. So, welcome everybody to the AHIP study hall. We love doing this, it's fun, and I hope you enjoy what we do. All right, here we go. So, today we're going to go over Class 1, and today we are themed Donkey Kong. Do you remember this feeling? Maybe you're too young, so just humorous, but this was our first digital game console, and it was called Atari, or at least it was for me. We themed these AHIP for those who haven't been here. We always love to theme it and just make it extra fun. So before Atari, we had checkers, hide and seek. So when when the Atari came out, it was the next obvious step toward flying cars. Why Atari is number one. It was so groovy, and you should totally believe us because we were pretty groovy ourselves back in the day. Don't watch TV tonight, play it. So what does this have to do with AHIP? Absolutely nothing. We've just been looking for an excuse to wax nostalgia. Ready for some fun? Let's dive in and study. Donkey Kong style. Medicare Basics and Program Overview. Basics. Medicare is a federal health insurance program for those aged 65 and older or Medicare eligible due to disability. Medicare eligibility does not take in consideration an individual's income. That would be Medicaid. However, some beneficiaries may pay higher premiums based on income, and low-income beneficiaries may be eligible for additional assistance. Individuals can receive their Medicare medical coverage directly from the federal government, which pays for services on a fee-for-service basis through a private health plan, and beneficiaries must receive their Part D outpatient drug benefits through a private health plan. If I were you, I would pay extra attention to this one right here. Even if they got their medical coverage through original Medicare, they will need to sign up for a standalone PDP. Medicare began as a fee-for-service program, now referred to as Original Medicare, under which beneficiaries could receive healthcare benefits from any Medicare provider and have the provider paid directly from the federal government through its administrative contractors. Medicare evolved to give beneficiaries the option of receiving their benefits and care through managed care options that are maintained contracts with networks of providers. Beginning in 2006, Medicare began providing coverage for outpatient prescription drugs through private health plans. I cannot stress enough that you need to know that Original Medicare utilizes private health plans for Part D coverage. View of Medicare benefits and coverage. Medicare coverage is often known by the part of Medicare law under which it is authorized or regulated. Parts A and B define the basic Medicare benefits. These benefits are covered regardless of how an individual chooses to receive their Medicare benefits. Part A is referred to as hospital insurance benefits, but also covers inpatient benefits and home health services. Part A provides coverage for skilled nursing and rehab care up to 100 days, but only after a 3-day hospital stay. MA plans may waive the 3-day stay requirement. That first block is important to know. Inpatient hospital care, including care provided by acute care hospitals, critical access hospitals, inpatient rehab facilities, and long-term care hospitals. And you get up to 100 days of home health care after individual is in a hospital or skilled nursing facility. That is not correct, and I'm not sure why it's that way. They get 100 days skilled nursing. Home health has a different contract. Inpatient psychiatric care is 190 lifetime days. blood, and hospice care are covered under those. The overview of Medicare benefits and coverage to Part B. Part B is referred to as supplementary medical insurance benefits. It covers a broad range of outpatient services. Part B generally covers physician, outpatient hospital, labs, diagnostic, durable medical equipment known as DME, home health care that is not covered under Part A because the individual is not in a hospital or skilled nursing facility or has exceeded the 100 days in the skilled nursing facility. Physical and occupational therapy. That's the thing I hear about the most from whether I'm talking to healthcare systems or agents or beneficiaries for that matter, is that there seems to be a lot of confusion about physical and occupational therapy. So we will dive into that much deeper as we progress along through our courses. Ambulatory surgical center services and chemotherapy on an outpatient basis. There are many other drugs that Part B covers, not just chemotherapy. So think of it as when you're going through this test and through your careers, that if there is a medication that is being injected into a patient through like an IV or chemotherapy, it will likely be a Part B drug if it needs to be infused. Other Part B items and services, ambulances, chiropractic, opioid use disorder treatment, kidney dialysis, diabetic supplies, certain preventative health services such as vaccines. And we'll get more into that when we get into that module for that, because I don't want to start confusing things as we go down and we prepare for our tests. Outpatient mental health, virtual check-ins, and continuous positive airway pressure known as CPAP. Medicare Advantage plans are private insurance plans that contract with government to provide Medicare benefits. They must cover all of Part A except for hospice, which is on the test. You need to know that original Medicare covers hospice and Part B services, and often include additional benefits not offered by original Medicare. Beneficiaries enrolled in Part C plans still get hospice benefits, but Medicare pays for them. That is on the test. An overview of Medicare benefits Part D. Part D provides prescription drug benefits for self-administered medications, such as those obtained from a pharmacy and taken at home. Part D also regulates Medicare prescription drug plans. Part D drug benefits are only available through private health plans. That is on the test. Make special note of that. Whoops. See, I was just trying to point it out and I clicked it. Sorry about that. This includes certain Medicare Advantage plans, Medicare cost plans, PACE plans, and standalone Medicare prescription drug plans. So remember, Part D drugs are only allowed through private health plans, including those that are embedded in Medicare Advantage, cost plans, and PACE plans, and standalone PDPs. There is also lesser known Part E of Medicare law that regulates other miscellaneous programs, including Medicare cost plans, which also cover Part A and B benefits. Medicare cost plans are only offered in a limited number of states and are most frequently found in rural areas. Medicare supplement, known as Medigap plans, the program for all-inclusive care for elderly PACE. Has anybody heard of Part E before today? Crickets?
Just in the study, but I've never had a situation where I actually had to know about it in like an appointment or anything.
Yes, and this is the first year it's made its appearance in AHIP. So I want to make special note of that. Part E has not been discussed in AHIP before this year since I've been doing these classes. Different ways to get Medicare. Beneficiaries have various options for how they can receive their Medicare coverage. Original Medicare covers only Part A and B benefits. Under Original Medicare, beneficiaries can receive covered service from any physician or facility that accepts Medicare anywhere in the United States. That is on the test as well. No referrals are required under Original Medicare. I don't know. Well, we'll get in that later. Original Medicare has substantial deductibles and other cost sharing. Original Medicare can optionally be combined with a Medicare supplement known as Medigap or a standalone prescription drug plan. Medicare Advantage plans, Part C health plans with or without Part D benefits, PDPs, and cost plans and PACE. Eligibility for Part A and B. First, the most common is to be age 65 or older or under the age 65 with certain disabilities or health conditions, including, I don't know why it says that, or other health conditions. To qualify for Medicare, you must be a U.S. citizen or U.S. resident or lawful permanent resident of the who has lived in the United States for up to 5 consecutive years leading up to your application. The part where it says 02 is super important to know that there is a question that asks if a certain individual who has lawfully been a resident of the United States, and it gives a date range, and the answer is yes. May I help you? Did somebody have a question? Okay, moving on. Individuals with end-stage renal disease. Beneficiaries eligible for Medicare based in ESRD generally lose eligibility. This is important to know. 36 months after the month in which the individual receives a kidney transplant, unless the individual is eligible for Medicare on another basis, such as age or disability. However, such individuals may remain enrolled in Part B only, but solely for the coverage of immunosuppressive drugs if they have no other healthcare coverage that would cover the drugs. This I would take a picture of. You will need to note this multiple times while going through AHIP. Leave it up for just a second. Okay, moving on. Some beneficiaries are automatically enrolled in Parts A and B. Individuals who are already getting benefits from Social Security or the Railroad Retirement Board will automatically be enrolled in Part A and B starting the first day of the month they turn 65. If their birthday is on the first day of the month, Part A and B will start the first day of the prior month. That is important to know. Does everybody understand that? That if they are already receiving Social Security or RRB benefits, they will automatically be enrolled in Part A and B. Starting the first day of the month they turn 65 is when that coverage will begin. If their birthday is on the first day of the month, the Part A and B will start the first day of the month before. These individuals are also allowed to refuse Part B coverage. Individuals with disabilities who are under 65 are automatically enrolled in A and B the month after they receive Social Security or their Railroad Retirement Disability benefits for 24 months. However, they have an opportunity to refuse Part B if they wish to not have it and pay for it. Individuals with ALS get A and B automatically begin the month of their Social Security benefits, disability benefits begin. Part B exception for beneficiaries living in Puerto Rico, they are not automatically enrolled in B, they must sign up for it. So if you work with anybody in Puerto Rico, we do not currently have clients in Puerto Rico, but who knows, you might have a license and might want to help them. They have to enroll, they have to initiate it.
Taryn, I have a quick question about that. So if they're taking Social Security already, but they're going to continue working after 65 and they want to defer Part B, but they automatically get enrolled, is there like a period of time that they get notified and then they can elect to defer Part B without them starting to take that premium on that birthday?
No, they're not going to get notification. They need to initiate that conversation with the Social Security Administration and let them know that they have a wish to put their Part B on hold. Oh, I see you raised your hand. I'm sorry, I can't see the screen with you all on it. So just feel
I
free
don't,
to
no
interrupt.
worries. So just to
It's watching.
reiterate,
I was just about to interrupt you and she did instead. So we're good.
so just to reiterate, if they're like, say they take early Social Security at 62, but they continue working, they're with a qualified plan with an employer at 65, they're automatically going to be enrolled in Part A and B. And if they don't know that, say for example, like how would they know that that's going to happen and that they're going to be charged for Part B premium even though they have an employer plan?
Well, there's no way for Medicare to know they have an employer plan. So the responsibility becomes to them to initiate that conversation. They can also still, if that time has come and gone in preparation of turning 65, then they can still call and put that on hold moving forward, and they'll be able to pick it up later on when they are ready for it. So this is the reason people need to be connected with an agent before their 65th birthday to be advised to go to Social Security and put their Part B on hold.
Okay, that's really good to know because I didn't know that part. So that's great.
Okay.
Thank you.
You're welcome. And you'll learn more about that as we go through AHIP some more. Other individuals will have to sign up if they want to be enrolled in A and or B. Individuals who are close to 65 but are not getting benefits from Social Security or the Railroad Retirement Board, I have such a hard time with that, may sign up for Parts A and B during their Part A and B initial enrollment period, which begins 3 months before their 65th birthday, including the month they turn 65 and ends 3 months after. Individuals with end-stage renal disease may sign up for Medicare at any time. However, the date on which Medicare coverage begins is usually the 4th month after dialysis treatments begin, but may be earlier if certain conditions are met. Make note of that. Individuals with end-stage renal disease may sign up for Medicare at any time. However, the date on which Medicare coverage begins is usually the 4th month after dialysis treatments begin, but may be earlier if certain conditions are met. Individuals eligible for premium-free Part A can also sign up for Part A at any time after they turn 65. Their Part A cannot start earlier than the month they turn 65. If they have not signed up by the time they apply for Social Security, they will automatically be signed up and coverage will be retroactive for 6 months. Individuals who do not enroll in Part B or Part A if they have to buy it when they are first eligible can enroll during Part A and Part B general enrollment period known as GEP each year from January 1st to March 31st. Coverage begins the first day of the month following the month in which the beneficiary enrolls. Individuals who have group health plan coverage based on their current employment or the employment of a spouse may enroll in Part A if they have to buy it, and or Part B anytime while covered under the group health plan or during a Part A and Part B special enrollment period that occurs during the 8th month period immediately following the last month they have group coverage. That is important to know. They have 8 months after the last month they have group coverage. That's what you need to know, that part. 8-month period immediately following the last month they have group coverage. Individuals eligible for premium-free Part A may sign up at any time. There are also Part A and B special enrollment periods that allow individuals to enroll after the Part A and B initial enrollment period due to issues such as emergencies or federally declared disasters in their area, release from incarceration, loss of Medicaid, health plan, or employer error that caused them to miss an IEP or other exceptional conditions. But what I would look at on this is that 8-month period immediately following the last month they have group coverage. Medicare Part A entitlement and Part B enrollment. A beneficiary is entitled to Part A if they are eligible for premium-free Part A, or if they have enrolled in Part A and continue to pay the premium or have the premium paid for on their behalf. To enroll and stay enrolled in Part B, beneficiaries must pay the Part B premium or have it paid on their behalf. Some employers, what that means, for some of those that are new, some employers, if you stay and retire with them, they give you a period of time, or even if you work for them still, they will pay that Part B premium for you. It's a benefit that they like to give. Beneficiaries are entitled to Part A without paying a premium for individuals ages 65 or older. To be entitled into premium-free Part A, the individual or their spouse must have worked and paid taxes for at least 10 years. It's important to know on this, the second note right here, that if a spouse has not worked, but their other spouse has, they are included in those quarters that their spouse has worked. If I couldn't have said that more confusing, what I'm trying to say is that if a spouse has worked and put in the quarters, their spouse will be eligible for the Part A, premium-free Part A, age 65 and older. All individuals eligible for Medicare due to disability, ESRD, or ALS are eligible for premium-free Part A. For those individuals who do not automatically qualify for free Part A, the monthly premium for 2025 was $518 for individuals or their spouses who paid Medicare taxes less than 30 quarters, $285 for individuals or their spouses who paid Medicare taxes for 30 to 39 quarters. But the free Part A or no cost Part A is for those who have worked the appropriate amount of quarters. Individuals who are not eligible for premium-free Part A and those who don't buy Part A when they are first eligible may pay a late penalty of up to 10% unless they enroll during a special enrollment period. They will have to pay the higher premium for twice the number of years they could have had Part A but did not sign up. That is on the test. So this last bullet point, individuals who are not eligible for premium-free Part A and those who don't buy Part A when they are eligible may pay a late penalty of up to 10% unless they enroll during a special enrollment period. The important part to know is they will have to pay the higher premium for twice the number of years they could have had Part A but did not sign up. So if they didn't sign up for 2 years, they will pay the higher premium for 4 years. Beneficiaries with income in 2023 for what was paid in 2025 over $106,000 or filing jointly with incomes over $212,000 pay more in 2025 up to $628.90 a month based on IRMA. So I added the table in here. Please take a picture of it. This again is for 2025. AHIP did not have the updated information for 2026. And of course, we will push that out as soon as we're made aware of it. Part B premiums can be deducted directly from Social Security, Railroad Retirement, or Office of Personnel Management, Civil Service annuity checks. If an individual does not receive any of these checks, they will receive a bill for premiums from Medicare every 3 months. Pay attention to they will receive a bill from Medicare every 3 months if they do not have it deducted. Employers may pay monthly Part B premiums on behalf of retirees. If individuals do not enroll in Part B when they are first eligible, their Part B premium will increase by 10% for each 12-month period that they could have enrolled but did not. This increase is referred as late enrollment penalty, we know it as LEP. Exception from the penalty. Individuals who have group health plan based on their current employment or the employment of a spouse are not subject to premium increase penalty if they enroll in Part B anytime while covered under the group health plan or during an SEP that occurs during the 8 months immediately following the last day they have group coverage. So that period again, you're going to hear this multiple times and it's on the test in multiple areas. In addition, individuals enrolling during any other SEP are not subject to the penalty. Any questions, guys?
Yes, I have one question on the hospice. So I was under the impression that Part A was hospital and hospice. Is that not correct? Is hospice now under Part B, or was always, and I had that wrong?
You had that incorrect, and we'll be diving into that. There's other parts where it may make more sense in
Okay,
some modules for you. Yes,
thank you.
you're welcome. Beneficiaries with lower incomes and assets may qualify for help to pay Medicare Part A and B premiums, the Part A and B deductibles, and cost sharing, and some Part D prescription drug costs. Beneficiaries may apply for the following programs through their state Medicaid office. And Medicare Savings Program assists with payments for Medicare Parts A and B premiums, deductibles, and cost sharing. Part D Low Income Subsidy, aka Extra Help. We all love Extra Help. Assistance is available for those needing help with paying for prescription drug coverage. Those individuals interested in support specifically for Part D can call Social Security or apply online. I highly recommend that everybody applies online if they are computer savvy. It's a lot more simple. They receive a letter within 1 to 2 days after it's been processed saying they've been approved or denied. Please note that this extra help is not available in Puerto Rico, the U.S. Virgin Islands, Guam, or any of those other places listed. Medicaid helps with healthcare costs not covered by Medicare, such as custodial long-term care. We list that out, and it is listed in AHIP because I believe there's some confusion with agents and beneficiaries alike that skilled nursing after hospitalization is not long-term care. That is simply only to get them rehabilitated or in a place where they can go home and be on home health care or a little bit more equipped to take care of themselves. Beneficiaries who do not qualify for the Part D low income subsidy but are of limited means may qualify for help paying Part D drug costs through the state's pharmaceutical assistance program. And they can call 1-800-Medicare, of course. Original Medicare cost sharing. In 2025, beneficiaries pay the following amounts for inpatient hospital care covered under Medicare: a $1,676 deductible for each benefit period. Is everybody aware that it is in Part A, it is a benefit period, not an annual deductible? If not, here we go. A benefit period begins the day an individual is admitted to a hospital or a skilled nursing facility and ends when the individual has not received hospital or skilled nursing facility for 60 days in a row. I list that out because there seems to be a lot of agent confusion about that as well. When does the 60 days begin? So there it is. Days 1 through 60, after the deductible has been met, they will pay $0 in cost share. Days 61 through 90, if they are still in the hospital, they have a $419 copayment per day of each benefit period. Days 91 through 120 are $138 copayment per lifetime reserve day after the 90 for each benefit period. Lifetime reserve days are days a beneficiary must use after they have been in an inpatient hospital for 90 days. A beneficiary has 60 such days to use in their lifetime. Beyond the lifetime reserve days, all cost. So what's important about this? That deductible resets after the 60 days if they have gone home and do not return. In 2025, beneficiaries pay the following amounts for skilled nursing and rehab: $0 for days 1 through 20, $209.50 days 21 through 100, and all costs after starting on day 101. In 2025, beneficiaries pay the following amounts for Part B services covered under Original Medicare. It has a $257 annual deductible, where before on Part A, it's a benefit period deductible. Part B is an annual deductible. After the deductible is met, beneficiaries typically pay 20% of the Medicare approved costs for Part B covered services. Beneficiaries have no cost sharing for most preventative services. Appeals related to original Medicare Part A and Part B coverage. In Module A, there's not, on one test I took, there wasn't a ton of questions regarding this, but there is in the final. Beneficiaries who receive Part A or Part B services through original Medicare have the right to appeal a decision regarding Medicare coverage and payment. Beneficiaries must appeal the services within 120 days. That is key to know, that 120 days of receiving the MSN, which is a Medicare Summary Notice, which details the financial responsibility, includes submission instructions. So it'll indicate how they can file that appeal. Of course, hopefully they call you so that you can help them and retain that client if they're unsatisfied. Beneficiaries who believe their hospital, skilled nursing, home health, rehab, or hospice services are ending too soon can request a fast appeal. They will receive a written notice from their provider explaining how to do this. Requests for a fast appeal must be made by noon the day after receiving the termination notice. So this happens a lot in the hospital setting, sometimes in rehab, where they're rehabbing a hip or a back. So the caseworker helping that patient will likely get that notice, as well as the beneficiary, and will go start working on their behalf. But it's important to know how this lays out, that they have until noon, by noon, the day after receiving the notice that they will be discharged from the hospital, skilled nursing, or home health will be ending. If a beneficiary disagrees with the appeal decision, they have 180 days after getting the decision notice to request reconsideration by a qualified independent contractor. Through this AHIP, you'll be seeing those referred to as QIC. Grievances. Beneficiaries may also file complaints about their Medicare providers or quality of care they receive. For example, a beneficiary may have a complaint about unprofessional conduct by a provider, improper care, unsafe conditions, abuse by a provider, or long waiting times or unclean conditions. So if they go to a provider and it is not clean, that is a reason for a grievance. Part D's. Prescription drug coverage. A beneficiary in original Medicare may receive Part D prescription drug through a standalone PDP, generally except for those dually eligible. For Medicare and Medicaid, Medicare beneficiaries must actively select a Part D plan. Beneficiaries who enroll in Part D typically pay a monthly premium, annual deductible, and a prescription cost sharing. I don't know about you all, but I'm starting to see people with more expensive drugs. We are starting to see those $0 PDPs not have as great a coverage as those with a premium. So we'll be seeing a lot of that. When choosing a Part D plan, beneficiaries should consider expected premiums, cost sharing formularies, and network pharmacies, meaning that when talking with you, you need to go over those things. Medigap coverage. How many of you love selling Medicare supplements?
I do.
Me too. I'm starting to, and I come from a Medicare Advantage background, so it's kind of fun. Medigap Medicare supplement insurance works only with original Medicare. It is illegal to sell a Medigap plan to someone already on a Medicare Advantage health plan. You need to know that first box. Medigap is sold by private insurance companies to fill in the quote-unquote gaps in original Medicare coverage, such as all or part of the deductibles and coinsurance amounts. The biggest thing that I see that is important for people to know, why not just get an original Medicare and why they may want a Medicare supplement plan, is because why? Charlie, I say this all the time. There is no stop loss. She had an answer cited for her. We need to remember that is the biggest answer that we give people when they say, why wouldn't I just have original Medicare without anything, whether it's Medicare Advantage, whether it's a PACE plan, whether it's cost, whether it's a supplement, whatever form of insurance they are most interested in, is because original Medicare, there is not a stop loss. So you are literally, that beneficiary, Medicare beneficiary, is responsible for 20% of a lot. And 20% of a lot, I always say this, is a lot. So we need to make sure we get that point across. Some Medigap policies cover limited benefits not covered by Part A or B of original Medicare, such as extra days for inpatient hospitalization, foreign travel, emergency care. Generally, Medigap doesn't cover long-term care like care in a nursing home, vision, dental, hearing, eyeglasses, or private duty nursing. Medigap policies are also available in standardized benefit plans identified by certain letters between the letters A through N. However, different plans are offered in Massachusetts, Minnesota, and Wisconsin. States determine which standardized benefits plans may be offered in their state. So it's up to your state and the states that you're licensed in to decide which letters they are going to offer to their beneficiaries. Turning age 65 and signing up for Part B triggers a 6-month Medigap open enrollment period when Medigap insurers must issue a beneficiary a policy regardless of any pre-existing conditions. This is called their guaranteed issue right. Make note of that. In certain limited instances, leaving a Medicare Advantage plan may trigger a guaranteed issue right. The only condition that I'm aware of, and this is a side note and it's not on the test, but the only, and I'm just interested if anybody has any insight, is if a plan leaves a certain area. Does anybody else know of any situation outside of the 6-month guaranteed issue right and a plan, Medicare Advantage plan pulling out? Is anybody else aware of any other guaranteed issues?
Yes. Right. So in the state of Washington, and there's 2 other states, but I don't know what those are. For some reason, we have a right to change 365 days a year without medical underwriting. So this is putting me in a great position with people who are in those old F and C plans that are closed and they're paying these huge premiums. I'm bringing them over to the N or the G plan, like for $146 a month. And we have the right to change 365 days a year with no medical underwriting. I don't remember what the other 2 states are, but that's and I'm in the state of Washington for anyone who is writing in the state of Washington. It's been a great way for me to really capture a lot of business and save people tons of money. Because like the people I've been helping, they're in their 80s. They're paying somewhere up around $325 to $385 a month for those old F plans. And even though there are a few different co-pays that they would have to pay moving over to an N plan, they're so minimal that it's just saving people lots of money. So that's one thing I know.
And I do want to reiterate, when the states that do have that rule, you are correct, and in the birthday rule, those only apply from MedSup to MedSup, not Medicare Advantage to MedSup. So in other words, if you're on a Medicare Advantage plan, I don't know that would work. I'd have to dig into it. But when you move somebody from Plan F, you are correct, Darlene. There are states and there are birthday rules that allow for them to be moved guaranteed issue into a MedSup that is equal to or lesser than the plan that they are currently enrolled without medical underwriting. Medigap, thank you, Darlene. Medigap plans are regulated by states, each with its own laws. Some states provide extra guaranteed issue rights, just like Darlene mentioned, and have specific marketing and commission regulations. Agents should understand their state's requirements for selling Medigap plans. I don't like it. It says your state's requirements in AHIP, but we need to know in every market that we're selling, we need to have an idea at least of what the laws are and understanding, especially when we're selling MedSup. Part A, coinsurance. Coverage for, what is this? Okay, coverage for 365 additional hospital days, Part B coinsurance, blood first 3 pints, hospice, care coinsurance, or copayment. I'm not sure what that slide is there for. I did not do that one. Beneficiaries with Medigap plans with and without drug coverage. Individuals who are enrolled in Medigap plans may only obtain Medicare drug coverage through a standalone prescription drug plan. To enroll in Part D, individuals who have a Medigap plans H, I, or J can have a Part D plan that's included in it. Those have been long ago. They're not very familiar. Keep their Medigap coverage with the drug portion removed and enroll in Part D PDP plan. Drop their Medigap coverage and enroll in MAPD or other health plan with a PDP. If a Medigap policy does not provide credible prescription drug coverage, the beneficiary may incur a late enrollment penalty. Credible coverage means the drug benefits are at least as good as Medicare's standard drug coverage. That is in the test. This last part right here. Credible coverage means the drug benefits are at least as good as Medicare standard drug coverage. Medigap rules for individuals who became eligible for Medicare after December 31st, 2019. Individuals who turned 65 or became eligible for Medicare due to age, disability, or end-stage renal disease on or after January 1st, 2020 cannot buy a Medigap plan that covers the Part B deductible. This includes plans C and F and high. Why does that say C? Plans F and high deductible F, as well as non-standard packages and waiver states. Individuals previously enrolled in plans that cover Part B deductible may remain enrolled in those plans. So like to Darlene's point, there are people who still have a plan F, and obviously they're getting hit with these increases, these plan increases, to where it's just becoming not unaffordable. And they do in the state of Washington State, where Darlene is, as she mentioned, she can move them over and get them in a plan that does not cover Part B. In Plan G or N. Plan G, the only money that they'd be subjected to is the $257 Part B deductible. Individuals who became eligible for Medicare before 2020 may still enroll in the plans that cover the Part B deductible. We get a lot of questions about that because we have the people who are grandfathered in, but if they can qualify for a Plan F and they turn 65 before 2020, they absolutely still can if they want to pay those premiums. I would definitely lean into the Plan G.
Taryn. Oh, sorry.
Go ahead, Darlene.
Thank you. When it said Part C and F, this was really confusing to me when I started selling supplements, because I always thought Part C was our Medicare Advantage, but the Part C is like what the Part N is to the Part G, right? It's the lesser, it's the least expensive one and has a few more things that you pay for. The Part C and F is like the equivalent to the N and G now, where the N's less expensive, but it has a few more cost shares.
So typically when we talk about Part C, we're talking about a Medicare Advantage plan.
Yeah.
There's a select Plan K that covers less, and those have ultimately, if they are still around, they're being phased out and they're trying to rejuvenate those. So yes, you are correct. But Charlie,
yeah, that was really confusing to me when I started selling supplement plans, trying to get people out of the old F plan, because I thought that was the only one. And then I helped a lady, she had a C plan. I'm like, no, if you have a C plan, you've got a Medicare Advantage. She's like, no, this is a supplement plan. So I kind of had, a learning curve on that one, that on the Medigap side, that F and C were the original, or, the ones most people were in, or whatever. Anyway.
Yeah.
What
Charlie?
helps me, this is Faith.
Yeah.
What helps me is to remember to call the supplement plans, Plan C, Plan F, etc. So it's not a Part C. Part C is Medicare, and Plan C is supplement. So just make sure you're using the right name for it
Mm,
to limit confusion.
mm.
For those who don't know Faith, she's been in this industry a very long time, and she started the company that the carrier that Charlie and I used to work for. Where was I? I got so lost by you, Darlene. I've lost my place.
I am so
Steven,
sorry,
I
but
was-
I really appreciate that, Faith,
Sorry.
because that really helps me actually, especially for a new agent, because I didn't know the difference, right? So I
Yeah.
appreciate that input, and I can share that, with Katie and Jessica, like if it ever comes up.
Karen, you had not started this slide yet. This was,
Thank
you
you,
just looked
Charlie.
over. No problem.
I was like, where was I? I don't remember reading any of this. Medigap plans. There's a high deductible version of Plan F available in some states, which is only offered to individuals eligible before January 1st, 2020. By 2025, a policyholder must pay $2,870 before the Medigap policy provides any coverage. Plan N has a copayment of up to $20 for physician office visits and up to $50 for emergency room visits waived in certain circumstances. We all know that to mean definitely if they're admitted. Plans K and L pay 100% after out-of-pocket limit is reached. In 2025, the out-of-pocket limits for plans K and L are $7,220 and $3,610 respectively. There's a high deductible version of Plan G available in some states with a deductible of $2,870 for 2025. There was nothing to note on that slide, by the way. That's why I went fast. Medicare coordination with employer group plans. These are what I would pay attention to in Module 1. The rules for what types of health plans employers may offer to their Medicare eligible employees and whether Medicare or the group health plan pays primary depend on several factors, including the coverages offered by a large group health plan. A large group health plan known as GHP has 20 or more employees for each working day in each of the 20 or more calendar weeks in the current year or the preceding calendar year. If the beneficiary has coverage under the individual's or the individual spouse's current employment. What you need to know is highlighted at the bottom. Medicare is primary for retirees covered under large group health plans. That is important to know. And the definition of what a large group health plan is, meaning 20 or more, is important to know. Medicare is primary for retirees covered under large group health plans. And that means groups of 20 or more. Medicare for individuals who are still working. Medicare law prohibits large group health plans from considering that an individual or the individual spouse covered under the group health plan based on current employment status is entitled to Medicare benefits. So what they're saying is large group health plans must provide the same benefits to the individuals age 65 or older and their spouses who are currently employed, matching those offered to those under 65. Prohibitions on large group health plans. Notice I put lots of stars by this. It is illegal for large group health plans to encourage employees who are eligible for Medicare to opt out of the employer's group health plan and enroll in Medicare instead. Additionally, the group health plan cannot offer these Medicare eligible employees different coverage compared to what's available to the employees who are not Medicare eligible. This includes offering its employees and their spouses Medicare Advantage, offering its employees and their spouses a Medicare supplement plan, individuals with group health plans coverage as a result of their or a spouse's current employment may choose not to enroll in Part B when it first becomes eligible. If they maintain the group health coverage, they will not have to pay a late enrollment penalty if they enroll later. The biggest thing to know right here, take a picture with your phones, is where this is starred. This is going to be asked in multiple ways. So just take a picture. Medicare is the primary payer for individuals with group health coverage from a company that does not offer a large group health plan due to their or their spouse's current employment. Medicare pays before the group health plan. Employers are not required to provide coverage for those eligible for Medicare. Small group health plans are not required to offer the same benefits to employees and their spouses age 65 and older as those provided to those under 65. Employers can choose to purchase or subsidize Medicare Advantage plans for their employees and spouses, or they can provide Medigap coverage, which is not restricted to standard plans. The individual and small group health plans should generally enroll in Medicare Part B when they become eligible for Medicare. Do I have questions in regard to anything regarding large group or small group? Because it gets tricky and confusing the way they ask the questions. Good, perfect. Okay. And if you have any questions, these are our emails, and most of you have my phone number, so you know how to call us. But if you would like any more information or have questions while you're studying, please do not hesitate to reach out to either Charlie or myself. And you'll notice that her email is charlene.howard, not charlie.howard. And I love to point that out. So, do we have any questions that we would like to dive into? Everybody's so quiet. I feel like I was reading forever.
On the skilled nursing, I did have a question on that slide. So on the skilled nursing, could you just go over that one more time with us, Taryn? So I'm a little bit confused about how that gets paid out.
Skilled nurse. I mean, there's a variety of ways that's going to get.
Hold on, let me grab the slide because I took a picture of it.
Well, I can bring up the slide. I just need to know what context your skilled nursing question is that you have confusion, because
go ahead.
Because depending on the plan, is it original Medicare? Is it a Med Sup? Is it Medicare Advantage?
Oh, that's what it was. It was the Med Sup. So the Med Sup, no, that was I had a question about the long-term care. So Med Sup doesn't cover necessarily long-term care. It was something on the skilled nursing with Medicare Advantage. I'm sorry, there were so many. So on the days 101 and beyond, all costs, that means they pay everything else. So the only time they're paying is days 21 to 100.
Yeah. So the idea of skilled nursing is if you've been in the hospital, say they had pneumonia or they had knee replacement surgery. The whole point of the skilled nursing facility benefit is to accommodate so that they can get home under home health. That is very temporary. You'll also know that in the case of Medicare Advantage, they get days 1 through 20. I mean, everybody gets days 1 through 20. Medicare Part A, original Medicare cost sharing. For skilled nursing, it's, you know, in a Medicare supplement, it picks up where Medicare leaves off. Although there are day restrictions, they can choose, you know, you would have to read the plan document. But on day 21, they will start having cost share unless they went from just a skilled nursing bed where they needed more assistance and now they're ready for rehab. That'll be a whole new authorization and they'll have a new benefit. But what they're saying, Darlene, is Medicare, whether you have a Medicare supplement or a Medicare Advantage plan or just original Medicare, it is not a substitute for long-term care. They will not pay for long-term care for people to live in those facilities, only to recoup, get better, and get home. That's what those are used for.
Okay, thank you.
You're welcome. Does anybody else have any questions? Okay,
See you
guys.
tomorrow.
See you tomorrow. Get ready tomorrow. Tomorrow is awful. It's huge. It's big. It's a lot. And interrupt me throughout the slide deck so that we can answer them when we're on that part, because it's over 50 slides long. So make sure to come with your questions tomorrow. And the module 1 test is very easy. You'll pass it, no problems. You can skip through to the test. We've already covered it. And then tomorrow we'll dive into module 2, where you'll get even more confused. But thank you for joining, guys. We really appreciate it. Bye.
Thank you.